Hello, hi. Thank you so much for the opportunity to present our ongoing research to the ID seminar. I'm Smita Charani, and I work at the Department of Infectious Diseases and HIV Medicine at the University of Cape Town. And today I'm going to be talking about research that we have underway, funded partly by the WHO, but also it speaks very much into two grants that we hold within our department from the Wellcome Trust. So if I minimize myself, wonderful. So you have heard me speak before about the research that we have been undertaking as part of various grants we had in the past at the University of Cape Town in collaboration with colleagues in the UK and in India, specifically trying to investigate how we implement infection control and antimicrobial stewardship interventions as part of multidisciplinary teams in hospital settings. Our research to date has highlighted many missed opportunities for better engagement with our colleagues across different disciplines within healthcare, but also with patients and carers. And if we look at the power dynamics that influence decision-making, it's very clear that there are many aspects of how we operate as teams that we don't fully understand when it comes to the promotion of implementation of interventions that are evidence-based. So we know the evidence base in relation to infectious diseases and specifically antimicrobial resistance in hospital settings, drug-resistant infections, and the spread of infections. However, we fail to implement interventions effectively. And a lot of it, we argue, is related to team dynamics, power differentials, and behavioral aspects. And our research has highlighted the power asymmetries that exist across and within professions. But beyond that, that are individual identities, layers of identities that we have based on our gender, based on our professional background, our ethnicity, our migrant status, caste and race, depending in different contexts, has an influence on the amount of power that we are given and power that we give ourselves when it comes to negotiating decision-making in the clinical setting. And this impacts clinical outcomes. And because of this, it's really important for us to be able to investigate these dynamics so that we better understand how we can implement interventions successfully. And when we talk about patients and carers, for example, even how we communicate with patients and carers is really important, and there are many lessons that we can learn. So, as I mentioned earlier, we have currently two major grants from the Wellcome Trust within our department, within our division, which we are working on. And the first is a Career Development Award, the Protea study, which is investigating the intersectionality of power dynamics, hierarchies, and health-seeking and health-providing behaviors in hospital settings across India and South Africa. And this is very closely linked to the CAMONET Centers for Antimicrobial Optimization Network grant that we have here. And this is part of a 5-country collaboration, which includes, in addition to South Africa, Uganda, India, Brazil, and the UK, with the vision to expand this network and focus on conducting research from different aspects, and that considers the optimization of antibiotic use in human populations. Alongside this research and work that we have been doing, myself and Professor Mendelsohn here in the department have been involved in the Lancet AMR series that are about to be published end of this month, that consider the implications of antimicrobial resistance and the burden of disease in different contexts, specifically in low and middle income countries. There are 4 papers, and the 4th paper really brings everything together and focuses on policy changes that need to be made urgently. But the paper that I was involved with is paper 2, and it considered the burden of bacterial antimicrobial resistance in low and middle income countries, using existing evidence to try and understand where the burden currently is and what interventions are most likely to provide the biggest return for investment in terms of the biggest impact on mitigating the spread of antimicrobial resistance. And using the existing evidence and developing modeling methodologies that was led by Joseph Lunard, our colleague, we have first demonstrated that actually we don't have a lot of robust evidence on antibiotic stewardship from low and middle income countries. And when we did the modeling, one of the things that was identified is that the biggest returns for investment are most likely to be in provision of WASH, water, hygiene and sanitation, and vaccination programs. Now, this doesn't mean that antimicrobial stewardship is going to be ineffective in low and middle income countries. It means that we have currently generated less robust evidence around this in these settings. And it is really important that we do this, that we work towards generating robust evidence that is contextualized, and we move away from parachute interventions that try to implement interventions that have been designed for different settings into others, which are going to not be sustainable and also not work in the long term. So because of this focus on WASH and sanitation, I'm going to be using a case study from a recent work that we have been awarded with the WHO to illustrate the importance and significance of access to WASH in different settings. And I'm very conscious that I'm an outsider in any context that I've been working, and the work in India I am conducting with colleagues there as an outside researcher, and the same in South Africa. So it's always important to have that awareness. But I wanted to highlight that the relationship that we have with water is compromised in many parts of the world, but its impact is different based on existing infrastructure and the way populations are currently living and the inequities that exist between high income countries and lower middle income countries. So as an example, these are beautiful cities in the UK, Cambridge and Oxford, and these are long established university cities, and there is an annual boat race that takes place, and the 169th boat race took place this year. And for the first time, it made the headlines for the wrong reasons, because the water in the Thames was so polluted with raw sewage that some of the athletes from the Cambridge team got so ill that it actually resulted in them not being able to compete effectively. But it also illustrated how policy failures can have an impact on our environment, and particularly in relation to antimicrobial resistance and infections, why this is important. And this is directly a result of policy failures because of the water companies not being able to cope with the regulations, and also because of Brexit partly changing the UK coming out of the EU, and the change in regulations has meant that a lot of water companies are now releasing raw sewage into the waterways and water systems, natural water systems in the UK. And, you know, there was a humorous take on this about at the same time, the UK is going through a crisis in relation to migrants crossing the channel in small boats. And again, it was a humorous take on what was happening on the left of the slide. However, the reality is the migrant crisis is also an example of a policy failure that is directly linked to health. A lot of the small boats crossing the channel the numbers have increased since Brexit. So it's linked to policy and the lack of the ability of the government to deal with it. And it's very easy to blame migrants for the problem without focusing on the reasons and the drivers for this. And the other thing to bear in mind, particularly with infectious diseases, a lot of time people may discuss this issue of migrants and infectious diseases associated with migrancy and movement of populations. And it's really important to realize that it is actually the conditions that result in people seeking to become migrants that cause disease, not it's important to understand that, and understand that it is war and displacement that put people in a vulnerable position, and the breakdown of their access to healthcare, but also breakdown of infrastructure and health where they are originally from, that causes disease, not necessarily migrants themselves. So we have recently been writing about the inequities between the global north and the global south in relation to antimicrobial resistance, and the policies that are often generated with agendas from the global north or high-income countries, for to use another term. And although these are very crude sort of definitions of countries, it is one way to define places where there are more resources versus places where there are less resources in terms of healthcare access, in terms of healthcare inequalities within populations. But what is really important to realize is that inequality is increasing in all countries. this is not just a problem that happens in lower middle income countries, but it is manifested differently and populations are affected differently based on locality. So before moving to Cape Town for my fellowship, I went to this play in the UK, Standing at the Sky's Edge, which is actually about a housing estate in Sheffield, the Park Hill estate, which has gone through many upheavals because of socio-economic deprivation, the closing of many of the industries in the north. And this play highlighted the impact of the socioeconomic disparities in the lives of people who lived in this estate through the decades. And it illustrates that this north-south divide can exist often and does exist within countries as well as across countries. And also segregation by socioeconomic status, by race, by ethnicity, by migrant status happens. It's a real issue that happens in different guises in different countries. As an example, this is from the King's Fund within England alone. There can be up to 10 years difference in life expectancy based on the wealth index of the different areas of the country. So the areas with the least wealth index and socioeconomic affluence, there is the highest degree of life, the lowest life expectancy versus parts of the country where are most affluent. And so this is, again, important to highlight. And I highlight this because later on in my talk, I'm going to be talking about India as an example of the relationship of populations with the water systems and access to wash and the influence of pharmaceutical industries. And I just wanted to put it in perspective that it isn't about blaming a certain country, but it is about highlighting how policy failures can cause harm and create vulnerability within populations in any country. And along that line, this was an article that was published by colleagues in Canada this week about this concept of social admissions, how often within health policies, particularly in high-income countries, the failure to cope or a lot of the socio-cultural conditions that make people dependent on the healthcare system, particularly in the elderly, particularly in those with mental health, are considered as failures on the side of the people or the patients themselves, whereas actually these are policy failures. And we need to talk about the social factors that drive health inequalities so that we can look at healthcare in a more holistic way and look and see how we can provide healthcare equitably. I have a PhD student that I'm co-supervising with Professor Alison Holmes at Imperial College in London, Alison Shutt, and she is looking at the evidence behind vulnerability in different populations and the threat and the spread of antimicrobial resistance. And we conducted a systematic review of the evidence for specific pathogens that cause diseases across community and hospital settings to try and understand whether there's any evidence by vulnerability. And, the first thing was, how do you define vulnerability? A lot of the indices that are used to define socioeconomic inequalities are country specific. And it is not appropriate to use those indices across different countries. So there's a lot of gaps from that perspective. Most of the evidence is around age and sex, education, attainment, employment, and income level. There is very little data across different populations by ethnicity, by migrant status, by disability to look at how we can define vulnerability in relation to antimicrobial resistance. We had a discussion about this at the recent ESCMID Global Conference in Barcelona. And one of the things that often is used to look at the impact of AMR in different populations that are considered to be vulnerable is to conduct a CAP study, a knowledge, attitudes, and practice study. And within the systematic review that we did, 40 of the 128 papers that we shortlisted that made it through to the final stage actually were CAP studies. But there's an issue with CAP studies in that we are conducting them in very different populations, asking very different questions. And we keep repeating these CAP studies without a pause to look at the existing evidence that is being generated and to try and learn from the data that has been gathered. What have we learned from these CAP studies? How have we implemented the knowledge that has been gained into interventions? How have we better engaged with the populations that we have conducted these CAP studies in? There is no evidence on that. And, this need for CAP studies came from a WHO report 10 years ago. But I would really advocate that it is time that we just pause and look at the evidence that is generated and move on without just mindlessly doing more and more CAP studies. I mentioned this or thoughts to this effect in social media last year when we were looking at the evidence, and one of our colleagues who is South African and is doing her PhD in Norway, Dr. Anja Nobut, contacted me and said, I was just about to do a CAP study for my thesis, and then I read your tweet, and now I don't know what to do. So we had a conversation about this, and Anja is now actually looking at the existing evidence from the CAP studies that have been conducted to date in the healthcare professional trainees. So whether they're nurses, pharmacists, doctors, physiotherapists, we are looking at what evidence there exists so that we can better understand the training needs and also have a sense of the questions that are being asked in this quite homogeneous population. And we're still asking very different questions depending on the country or the setting we're going to. So, there are other ways to do patient and public engagement work and understand the context with different populations. And one example that I use is the EWOSA, which is an NGO funded by the Wellcome Trust based in Kailicha. This is an NGO that is led by a scientist and an artist. So Tasha Koch is a TB scientist who is now co-directing EWOSA with Eddie Young, who's a visual artist and a PhD student. And they have a fantastic team based in Kailicha. Their team is from the population who live in Kailicha, and they have trained, and they are training other youth learners in how to engage about TB, AMR, and other public health related concerns in a sustainable way. And we're very fortunate to be able to work with EWOSA. One of the first pieces of work we did with them was to translate our imagery work that we had developed and work with these learners so that they can develop a documentary about what equitable representation means to them. And we're very excited. We're going to be screening these documentaries on Friday, 17th of May in Kailicha. So through our work with EWOSA and the grants that we have with the Wellcome Trust, an opportunity came for us to apply for a WHO TDR grant. And the call was to look at gender and antimicrobial resistance. And because myself and one of my colleagues, Dr. Deepshika Bateja, who's at the One Health Trust, sit on a WHO group on gender and AMR, we already knew the evidence base around that because we were conducting a review with the WHO. We decided to include climate. Now, this is a scoping grant. It's not a research grant, but we're conducting a systematic review to look at the intersection of AMR, gender, and climate. We're conducting a stakeholder mapping exercise, which Tasha led on, to identify the right people to bring to workshops, to have discussions, to begin to consider the lived experiences of people in different contexts, from different races and ethnicities and castes and gender, and see how these conditions that we are interested in is impacting their daily lives. We've had our first workshop in Bangalore with the One Health Trust in March. We have another 3 workshops planned in South Africa and another one planned in Chandigarh, PGI in August. And we're very excited about this work and the conversations that have generated from this. And, around climate and gender and AMR, there's actually not a lot of evidence generated, but that doesn't mean that this is not an area that needs to be looked at. So Deepshika and colleagues at the One Health Trust used publicly available data in the USA. This was a poster that they presented at Estimate Global in Barcelona. And they also looked at trends in temperature over time, climate in USA, and data that they have, when it was adjusted for socioeconomic status, for race, for gender, identified that using the antibiotic prescription data from pharmacies in the USA, a 1 Fahrenheit increase in temperature led to 5% increase in antibiotic use. Now, this is early data, and I guess it's too soon to make deep and detailed interpretations of it, but it is an area that we need to do more research on and understand how a rising climate is influencing or impacting our health. There's a lot of evidence about rises in climate change and impact on women's health, particularly during pregnancy and childbirth would increase in stillbirths. But there's an area that we need to do a lot of work on. And as I mentioned, with the WHO, we are working on a gender and AMR working group, and the report of that group is going to be published in the next few months. And it is advocating for countries to have a gender responsive approach to developing their national action plans for antimicrobial resistance. So as I mentioned, our first workshop was in Bangalore in March. It was led by Dr. Deepshika Bateja, and we had a fantastic discussions around how gender and antimicrobial resistance and climate intersect with one another in the context of India, bringing in the complexity of caste. And we worked with many fantastic people, including Nancy, who is a gender-based violence advocate and researcher, with Deepak, who is a climate activist, and with Himanji, who is a caste activist. And we learned a lot from our interactions and discussions, particularly around how much caste and gender intersect with one another in relation to healthcare access, and the health of individuals, and how it needs to be this intersectional lens needs to be taken into account when we do research in this subject. We had anticipated that that would be the only workshop in India. However, as luck would have it, through connections with Professor Nusrat Shafiq, who's the co-PI of Camonet India and a collaborator of mine for a few years, she introduced me to Dr. Arunima Sehal Mukherjee from HISP India, who's at University of Oslo, but all of her work is in Himachal Pradesh and Bihar, and I had the opportunity with them to go to many other workshops. And this is very important because in my fellowship, one of the weaknesses was that in our proposed research, we were only going to work with Kerala and with hospitals in Kerala and in Chandigarh, and the panel considered those to be two of the most affluent states in India. And one of the criticisms was that we actually needed to engage with other states where socioeconomic deprivation was more significant. So this was really a great opportunity for me to be able to have a experience of other settings. And we went to the town of Baddi, and I'm going to be using the town of Baddi as a case study to talk about the intersection of AMR with gender and climate and caste. And if you want to read about and understand the issue of caste in the culture of India, I would really recommend this book by P. Sainath, which is Everybody Loves a Good Drought. It's 20 years in publication, but it is a really informative book about how failed policies, or policies generally, health policies that do not consider the socioeconomic inequalities within populations can fail those who need health policies that are effective the most. And I think a lot of the issues that are discussed in this book matter to this day and are very important for us to consider. So we had a host of workshops in different, this is Dr. Arunima Sehal Mukherjee and her team. We had a whole host of workshops in different parts of Bihar and Himachal Pradesh, two of the most deprived states in India, and two of the states where caste is particularly important and caste-based politics are important. So I'm going to use the example of Badli to give you a window into why intersectionality matters in relation to antimicrobial resistance, particularly in lower middle income countries. This is the river Sisra, which runs from the foothills of the Himalayas through the town of Badli. And incidentally, on World Water Day, we had the opportunity to go to the source of the river and then follow it through into the town of Badli. And at the source, it's a beautiful river with clean water coming from the mountains, the snow that melts from the mountains. As it comes into the town of Badli, the river becomes more and more compromised and polluted. And the reason for this is Badli is an unplanned city that has come about as a result of increasing number of pharmaceutical and cosmetic industries that have plants there. There are over 3,000 pharmaceutical and cosmetic industries, and the town has been generated around this industry with a lot of migrant workers, a transient population. And there are over 200 informal settlements and over 70 vulnerable settlements in place around the town of Baddi. And a lot of these settlements have people who work in the factories as migrant laborers. All these factories release their effluent into the river. Most of these factories are releasing untreated effluent. And a lot of these factories are pharmaceutical factories, active pharmaceutical ingredient producers. And there is a tiered system. So primary manufacturers have more strict legislation around the release of effluents, but secondary and tertiary manufacturers have more relaxed regulation. And often the primary manufacturers are dependent on the secondary and tertiary manufacturers. So there is an ecosystem, there is a relationship between a cycle between these factories, and that is sometimes overlooked. So if a primary major international pharmaceutical organization is there and says that everything they do is according to legislation, it doesn't mean that they're still contributing. They're not. It does not mean that they are not contributing to the problem, because if they are dependent on secondary and tertiary factories that are releasing their untreated effluent into the water, it is still problematic. And then a bit further down, along these factories, there are many settlements along the river. And we went to one of these settlements, and 3 women and 2 men came to speak to us. And my colleagues who speak the local language and our researchers there, our AMR team, were translating for us. We asked the women how they deal with childbirth. And the man immediately spoke before the woman could and said, oh, there's no problem. It's absolutely fine. We're okay here. And the woman said, actually, no, it is a problem, because often we have to give birth in our huts or in our tents. Only if there is a complication, we are taken to the hospital. Now, the hospital is a drive away, and there's no paved road. There's no cemented road. It's a very shaky drive, and getting a vehicle is not very easy. And then we asked them about whether they have any concerns about the water in the river that they're living by. Again, the man said, no, there's no problem at all. We're okay. The woman spoke up and said, actually, it is us who have to wash our clothes and our dishes in the water. We grow vegetables by the river, and we have to go and feed the cattle and the animals that we keep in the water. And the water is extremely dirty. And when we come into contact with it for long periods of time, we get irritated skin conditions and blisters. And also when the river swells, when there is a flooding, we are the ones who have to pick up our homestead and go to higher ground. And then we asked them about their children and access to school. And they told us that because of their caste, often it is very difficult for them to have school books for their children. So their children cannot get adequate schooling, or that they can't get uniforms to be able to go to school. There was also another person who joined the conversation, and that person was a transgender, a hijra. And this is a recognized group of people in India. And he was speaking very animated. She was speaking very animatedly. And they were trying to silence her. And when my colleagues translated conversations for me, they said that what she was saying is that at least these people that you are speaking with can work. Because of who I am, I can't even work. Nobody will give me a job. I can only beg. So in that very short episode of conversation with these different individuals, we had a window into intersectionality in relation to health, particularly in relation to antibiotic resistance, because we could see how individuals' identities, whether it's gender or caste or education status, can have an impact on their relationship with their environment, but also on their health-seeking relationship and behaviors. It's also important to note again that a lot of these families keep their animals by the water, and some of them would say that every year a number of their animals dies, probably because of the water that they're drinking in the river is so polluted. In the town itself, there's over 3,000 pharmacies, registered pharmacies, and there are many unregistered pharmacies. Another question that we posed to the people that we spoke with in the settlements was how they seek healthcare generally. And they said that, oh, we don't have to go anywhere. The doctors come to us. And we delve into this a little more. And what they say is that these people in white coats come with medicines, and they give us medicines when we need them. Some of them even inject. Now, these doctors are actually youth who just wear a white coat, go and buy some powdered medicines from the pharmacy, some of it antibiotics, and indiscriminately sell it to these unsuspecting people who live in these settlements, who assume that this is a healthcare professional giving them healthcare. So despite these pharmacies, it's very important. These pharmacies probably are the first port of call, one would assume, for a lot of people. But actually, even before they come to these pharmacies, there are these quack doctors and other means to healthcare which is compromised, and where antibiotics are given inappropriately to these people, in addition to the exposure to the active pharmaceutical ingredients that they're getting through the polluted river water. So really, this for me was a point to reflect on the ecosystem that we are creating and compromising in relation to antimicrobial resistance in different settings. And, you know, a lot of our focus and Zoom is often in hospital settings, and we lose focus of all the other encounters and experiences that a patient may have before they reach us in the hospital that may have compromised their health, specifically in relation to antimicrobial resistance, that may have exposed them to drug-resistant pathogens and to antibiotics through the environment. And that we need to spend a lot more time focusing on what is happening in communities to be able to better understand the patterns of disease that we are seeing in the hospital settings. And for me, this diagram, which shows the relationship of the environment with antibiotic resistance and human and animal health, is really not that different from these pictures. This is a pictorial version of this diagram. And the story that I just told you is a real story of people who are experiencing this on a day-to-day basis. Of course, there is evidence from, this was a paper in Nature, that the highest concentration of drug-resistant pathogens in water sources in the natural environment, the highest is going to be in industrially polluted surface water, followed by untreated hospital effluent. So we really need to think about this much more carefully to understand what consequences of this are for antimicrobial resistance. Now, if you go to the website of a lot of the pharmaceutical industries and cosmetic industries that I had a chance to see what was happening in Badi, if you go to their websites, they tell a different story. So L'Oreal has, you know, for the planet and everything they're doing for the planet. There is a European Federation of Pharmaceutical Industries and Associations, and there's a lot of reassurance about the environmental impact of pharmaceutics. This may be true in countries where legislation is more strict, but it is not true everywhere. And we really need to get to a point where legislation around pharmaceuticals has a universal approach. And regardless of geography, we are protecting the environment. And by protecting the environment, we are protecting people from the unintended and harmful consequences of the pharmaceutical industry, particularly in release of active pharmaceutical ingredients and toxic effluents into water systems. This paper is very interesting because it compares existing legislation and the problems with environmental pollution by pharmaceutical industry, and it clearly highlights the social determinants of health are directly linked to environmental disparities. Now, whilst there is more regulation in high-income countries, it doesn't mean that we get everything right in high-income countries. As one example was from the river that I showed you at the beginning from the UK, but generally in all countries, it is often the marginalized communities that are subject to environmental segregation and come to most harm from the pollution that we are seeing in the environment. And there is a question whether we need to think about having a different approach to legislating and regulating this industry. Although I don't have the answer or the power for that, I really think we cannot rely on governments or pharmaceutical industry alone to deal with this governance issue. So some of the ongoing conversations that have emerged from these workshops, which are really informative for us, is this the concept of segregation, that it has many forms. Segregation can be occupational, residential, olfactory, depending on how close your house is to, for example, raw sewage being released into the environment. Mobility is linked to vulnerability, and mobility can be impacted by religion, by gender. For example, if females feel unsafe if we do not create safe environments for women, and they always need to have someone to go with them when they go out, their access to health and social welfare can be compromised. There can be exclusion in research based on gender. A lot of the community work may only capture the voices of men and not women if the women are busy conducting chores, or they are not as able to speak up about the issues that they have. In that one example I gave about the settlement by the river, it was the men who had an opinion about everything, and we had to really push to get the women to speak up. And two things that came up through conversations with physicians and doctors and clinicians on these trips was, the first we know about is that, particularly in private healthcare, in many settings, the more antibiotics a doctor prescribes, the more popular they are. And this can have an impact on practices. The second one, which I hadn't anticipated, is that there may be punitive actions if drugs are considered to be wasted, particularly in government hospitals. So often doctors were telling us, we will prescribe antibiotics because we are concerned that they will go out of date or be expired. And that has its own consequences for us. A recurring thing that we were told is that antibiotic stewardship is a luxury. Often in very resource compromised environments, it is not possible to implement antibiotic stewardship the way we think we should be doing it. And I think that's really important and speaks to the paper that we speaks to the Lancet series that is coming out about what interventions will matter most in different settings, and also the inequality paper in Lancet Global Health about contextualizing solutions to different settings. So where are we going next? We have a series of workshops, as I mentioned, in it was here in May and again in July. We have been awarded a photography award through EWOSA. They are leading on it, and we're very happy to be working with them to look at communicating about health and public health through photography with citizens. We have two grants that we are working on at the moment to carry on conducting research in this topic. And I think it's really important to also, when we talk about these intersections of gender, AMR, and climate, to be wary of unintended consequences that may cause more harm than good. Health washing is a term that is being used that sometimes, particularly with pharmaceutical industries or industries generally that are part of the problem, they may pose solutions that look like they are climate positive, but they actually may be causing more harm from a healthcare perspective, from a health perspective, and that's something to bear in mind. Thank you very much for listening to me. I have a lot of colleagues that I work with. I am fortunate to work with, and also I need to acknowledge our funders, and I hope that we can have this conversation. We can carry on the conversation. If you have any questions for me, you can always contact me. Thank you very much.